Once again, welcome to our Health Equity Series. This series is going to be focused on the effects of COVID-19 on health equity. And without further ado, I'm going to introduce Jim Poinsett, our Missouri Area Board Health Equity Lead, who's going to introduce our topic and our special guest speaker. Jim, I'm going to turn it over to you.
Great. Thank you, Jason, and welcome everyone to our June episode of our listening sessions about the topic of health equity, and specifically today, COVID and the pandemic's effect on health equity in the Missouri area. Friends, as Jason said, that I am part of the Missouri Area Board and have been assigned to be the lead on our efforts around health equity. And as all of you know, our work at ACS is to help people prevent, find, treat, and survive cancer. For us to meet any of those goals, prevention, screening, treatment, and survival, we also have learned in the past few years, or it's come to light, particularly during the pandemic, that we also need to start paying attention to our healthcare system and recognize the lack of access that there might be in parts of it, and the social determinants that impact the effectiveness of our efforts in fighting cancer. In other words, a key strategy for us to reach our goals as ACS is to work towards health equity. So we have some new people on this call this month, so if you haven't been following along with us, the recorded sessions and whatever, I think it's important that we always begin with a few key terms, so we're all using the same sort of vocabulary as we listen to our guest today speak, and we discuss with one another in ways to further the goal of health equity. So, and that's right there where we want to start, right? Health equity is a term that's used to describe the broad effort to provide access to quality health care for all. And the American Cancer Society has identified health equity education as one of the top needs for Missouri. So to help us learn about that, we have this series of videos. And I also want to, again, remind you of sort of the shared vocabulary that we will be using this afternoon and throughout this series. When we speak of health equity, we must keep in mind that health equity is actually the goal. What we're really talking about in our conversation today and subsequent conversations is we're really talking about the health disparities or the health inequities that must be addressed if our goals of beating cancer are to be reached. So when we speak of health inequities, this is what we're talking about: systemic, ingrained, and unjust barriers that prevent segments of the population from the opportunity to achieving their highest level of health and leading to health disparities. We'll also be talking today and in our other sessions about the social determinants of health. Those are things that impact healthcare, outcomes, such as proximity to doctors and hospitals and pharmacies, access to health insurance, access to prenatal care, level of education, socioeconomic status, availability of healthy, fresh foods and safe neighborhoods, and long-term stress. All of those things, and the list could go on and on. And finally, it's also important to understand the distinction between equality and equity when we're having these conversations. Equality is giving everyone the same exact resources, while equity is the distribution of resources that takes into account different circumstances to reach an equitable outcome. And so that is some of the vocabulary that you will be hearing, you will hear today in our conversation. And if you go back and hear the recorded sessions that we've had previously and join us for the subsequent sessions, I hope that you will be able to become more familiar with those terms, become more conversant in it, so that we can become more socially aware of how these things influence the work that we do at ACS and the ability for others to achieve healthy outcomes. And so today's topic is very important and very timely, and it is how the COVID-19 and the pandemic has affected health equity. And I am so pleased to have introduced and have with us today Dr. Alex Garza to help guide us through this conversation. Dr. Garza is the Chief Community Health Officer with SSM Health here in St. Louis. And as many of you probably know, he is also the head of the St. Louis Metropolitan Pandemic Task Force. So both of those roles give him great insight into focusing on the social determinants of health in his work at SSM, but also as his experience as the lead with the Pandemic Task Force, the unique ways of showing, of seeing how the pandemic has affected health disparity in our region and throughout the state. So Dr. Garza, welcome. Glad to have you with us today.
Well, thank you, Jim, and thanks for inviting me to talk about this important topic. If you don't mind, I'm just going to keep my camera off to save bandwidth, and then go ahead and pull my slides up, if that sounds good.
Sure. Let me just start with an opening question for you real quick. I was fortunate to be on, back in March, I was fortunate to be on a Focus St. Louis presentation that you did on the same subject, and back in March, I wrote this down on my pad that day, that we're not that far away from getting back to normal. And so I noticed yesterday that was the final public briefing of the Pandemic Task Force. Right. And so I want to say congratulations on that. But can we get just a quick summary of where are we now in terms of being able to be open and being out and about, and just an update on where you think things stand with the pandemic?
Yeah, no, good question, and thanks for writing that down. I don't count on people remembering things that I've said before. So I
was so desperate to get back to normal. I had to holding on for any morsel of hope, right?
Yeah. So I can speak to most informatively about the St. Louis region, of course, but we're looking pretty good. And I had some data on vaccinations later on the presentation, but the St. Louis metropolitan area is around 50% for first dose vaccinations, which is pretty good. The rest of the state is comparatively a little bit lower. They're down in the 30s. So we feel pretty good here in St. Louis, and that number is going to increase every day with more vaccinations occurring. What I also tell people is layered on top of that, and so that's a conservative number as well, and that's because of some data issues and things like that. So it's probably higher than that. And then you also have to remember that there are some people that have natural immunity that have chosen not to be vaccinated. And so the number keeps growing about the number of immune people that are in the population. What's more importantly, though, is a lot of the high-risk populations have had a very good uptake in vaccinations. And by that, I mean people that are in those older age categories and people with medical conditions that would put them at risk, such as cancer. And so they have been vaccinated at a higher rate than if you just lumped everybody together. And so what that translates into then is more people, even if we do see cases increase, that doesn't necessarily then translate into hospitalizations and deaths because it's a younger population now that's becoming infected. So certainly we don't want anybody to be infected and we want everybody to be vaccinated. But the chances of us having a repeat of what we saw in the fall and the winter are much lower now. And so that is a good thing. When we reach that sort of that golden egg of herd immunity is somewhat unknown because of all those different nuances. But we get there closer every day. And so I feel really comfortable with where we are right now.
Well, it's a good place to be in, much better than it was even back in March.
Oh, sure. Yeah. I was hoping you meant March of this year and not last year, right?
Well, yeah, I certainly did. I mean, yes, I certainly did.
Yeah. Okay. Yeah. So that's where we are. There's certainly some challenging places in the state of Missouri. You've probably heard about the Springfield area and the Northwest, North Central area, all areas of low vaccination rate. And there's no magic to it. You have an increased variant or a variant that is present. It's gonna infect at a higher rate. And then when you combine that with no public health measures and low vaccination uptake, it's just all, as I told somebody earlier today, it's all just it's all science and math is all it is. There's no other explanation for it.
Well, in my day job, I do a lot of work in doing vaccination outreach and education, and I do want to ask you about those things, but I also want to hear what you have prepared for today. So I'll come back to those after you share with us what you have to share.
Okay, awesome. I am going to go to share my screen here. And just let me know when you can see it, and then I'll go into presentation mode.
We can see it.
Okay, awesome. Okay, so as I typically do, I put way too many slides into a presentation, so I'm going to try and skip over as many as I can. But it's just such a broad topic; it's difficult sometimes to pull everything together that you want to. So what I thought I would do is talk about three things: of course, health equity and COVID, our current vaccination status, and I'm limiting my data to the St. Louis region because that's where we do all of our work. And then a few things about COVID and cancer, and then just some parting thoughts really quickly. So as some of you may or may not know, I worked for the Obama administration as the Chief Medical Officer for the Department of Homeland Security. And one quote that I've used quite frequently during the pandemic is this one. So the president said this, when disaster strikes, it tears the curtain away from the festering problems that we have beneath them. And I think this pandemic was no different than any other disaster that we've had in our nation, whether it's a hurricane, a tornado, whatever. The problems that we see from a lot of disasters aren't necessarily specific to the disaster. It's to a lot of the underlying issues that we have as a country, and equity is one of them. So I wrote this article in Health Progress, which is the magazine for the Catholic Health Association. And I will draw you to the date of the publication for this. It's November, December of 2019. And so in the summer of 2019, they asked if I would write an article about disaster preparedness based on my experience in the military, in Homeland Security, as a paramedic, as an emergency physician, so on and so forth. And of course I said, sure. And so I wrote this article, which I titled Guns, Germs, and Healthcare. And so they wanted it specifically about violence and about infectious disease. And so I borrowed the title from Guns, Germs, and Steel to show how guns and germs and healthcare all interact. And so this was the article that came out. And coincidentally, it came out in December of 2019, right before the pandemic kicked off. And so it was really weird reading my article in then the winter of 2020. And so I just pulled out a couple of quotes just to describe some of the thoughts about this. However scary a deliberate biological attack seems, nature is a much more prolific at developing and spreading serious infectious diseases than any nefarious state actor. The SARS pandemic is a good example on how disease is no longer isolated by geography and how serious illness can rapidly travel worldwide. Due to air travel, the Ebola crisis in Sierra Leone and Guinea in 2013 offers similar lessons on how fragile states, local culture, and environmental issues, when combined with a highly transmissible and lethal infectious agent, can bring about devastating effects. And we had that in spades here recently. In many ways, however, infectious diseases are similar to gun violence. They affect the poor and vulnerable disproportionately and can span from small intense episodes, such as meningitis or sepsis, to full-blown disasters such as H1N1 or the recent Ebola outbreaks. So again, all prior to the coronavirus 19 exploding onto the planet. So you briefly mentioned health disparities. I'm just going to run through this very quickly then, because I'm sure your audience all understands this. But if you think about what contributes to the health of an individual, and for that matter, the health of a community, it's many different things. And so if you look online, there's a couple of different ways of dividing this up. And so this is just one that I chose. I think all of them are directionally correct and precisely wrong. So we just have to be very cognizant of how much we attribute to these things. Medical care, though, I would argue, is a very small percentage of what makes up the health of the person. This estimate is 11%. I've seen 20%. Yeah, I think that's probably pretty fair, anywhere between 10 and 20%. But the other ones are much more impactful in the health of the individual. Actually, I think they undercut the physical environment, which was put at 7% in this paper. The individual behavior is 38%. And then if you look at social circumstances, around 23%, and then 21% of genetics and biology. So what does that mean? That means when we're working on other issues, on healthcare related issues, you really have to understand the entire context of how that contributes to the health of the individual. It's not just the delivery of healthcare. It's many other things that we need to be working on. And that's one of the main reasons why I became the Chief Community Health Officer, was to work on these other social determinants. So I'm just going to very briefly touch on some of my experience in Homeland Security, where we dealt a lot with risk. So a lot of these were terrorism risks and things like that, but we also dealt with pandemic risks. But I like to boil things down into some explainable equations. And so one of the things that we would talk about with risk was this equation of risk equals threat times vulnerability times consequences. And so I took this equation and I incorporated it into the pandemic situation that we were dealing with. And so these are from early on. I gave part of this lecture, gosh, probably about a year ago. And so the threat is ubiquitous for everybody within the pandemic. It's a virus. It's the coronavirus, the SARS-CoV-2 to be exact. And it's capable of human to human transmission. So everybody's at equal risk for contracting the virus from a threat perspective. And we'll talk about equity here in a second. And really the virus's main objective, or its main strategy, is to replicate in a susceptible host. And so oftentimes I think people subscribed too many human qualities to what really is the virus's only strategy, which is it only wants to make more of itself. It really doesn't care about political party. It doesn't care about culture. It doesn't care about anything else. That's all it wants to do. So if you understand its strategy, then you can defeat it. But if you try and impart what you think its strategy is, then you get in trouble. So vulnerability. So these are the things that make people more vulnerable. If there's a high level of contagion, if you interact with the public, if you don't have mitigation strategies, and then personal things also. So some of them are environmental, some are personal, and you can see cancer is up there, COPD, heart conditions, all of those things make the individual much more susceptible to COVID-19. So I'm going to focus specifically, though, on the environment, and some of those contribute to the personal, but just for simplicity's sake. So I've done a lot of work with the St. Louis University Geospatial Institute, and we tried to understand what are some of the contributing factors to higher COVID rates in our community. And again, these were early on when we were really starting to wrap our heads around what makes one community more susceptible to COVID than others. And so we started looking at travel patterns. And so we looked at, so this is actually the population of people that work in the food industry. And the reason why I say that is because they have high interaction with the public, okay? And so as you can see, this is North St. Louis City and North St. Louis County up over in here. And so high penetration of food employment, where the low is these blue areas, which is the more affluent areas of St. Louis County, okay? And then also with that is work and travel. So many of the people that work in here, so think about this, they have high interaction with the public and they have to travel, which means they take public transportation as well, which increases your risk of being exposed to COVID. So, and then we looked at health support employment and work travel. So health support is nursing home employees as well. And so as we all know, early on in the pandemic, those were especially hard hit. And again, the population which has very high poverty rates work in these low paying, low skilled jobs and have to travel quite a bit to get to their place of employment. And then professional employment, it's somewhat flipped, although you see the lower penetration now of people that in these areas that have professional employment, but some still have to travel. And so some of these down in here do have professional employment and have to work or have to travel quite a bit. But out in the more affluent areas, high professional employment with low work travel. So what does that mean? That means people that work in these professional environments didn't have to come into the office. They had a means to work from home, weren't exposed to anybody, could take care of themselves within their home. And so it's understanding how these patterns fit into the COVID infection rates was even more important than just looking at the zip code. It was looking at what does that represent in terms of how people work and how they do other things. So again, this is production, manufacturing, and travel. So this gave us great insight into who was most at risk for COVID-19 early on in the pandemic. So I'm going to go ahead and click through these really. This was just percent change so we could see before and after our the travel restrictions were in place, or not travel restrictions, but shelter in place, and how those affected different people. So rather than go through all of these individually, I think you get the point about there's differences between the different communities, and that explains a lot of why COVID impacted them more. And then the consequences, of course, were equally important. And so people that live in poverty have more severe threat of loss of wages, nutrition, and education because they work an hourly wage, so they need their paycheck to pay their bills. A lot of their children are on the lunch programs and the breakfast programs. So with the loss of that, that means they have to increase their food bills. And then, of course, the loss of education, a lot of people don't have access to broadband and things like that. And so their opportunities for education were much lower as well. And then on the health side, increases in morbidity and mortality. So as was mentioned, we formed the St. Louis Metropolitan Pandemic Task Force. These are slides from June 15th of 2020. So right about a year ago, we did our first cut of how COVID was affecting our community. And I'll just show you really briefly some of what we found. So the impacts in the Black community were 4 times to test positive, 4 times as likely to test positive, 2.5 times to be times more likely to be hospitalized, and 1.5 times more likely to be admitted to the ICU. And so this was a breakdown of what we saw just about a year ago of the Black population versus the non-Black population. So they were tested at just about the same percentage as they represent in the community, but they tested much higher percentage positive than they should have because of the percentage of people that they represented within the community. And then the admitted percentage as well. And so this is the percentage of African Americans that live in the St. Louis metropolitan statistical area. It's right around 20%. But you can see they represent 50% of those that tested positive and 60% of those that were admitted to the hospital. Now these changed over time, and I'm going to show those to you here in just a minute. But early on, this is what we were seeing. So we did not see, though, apologize, let me go back here real quick because I want to make a point with this. We did not see a difference in mortality, but the reason for that is because once patients got to the hospital, there was an equal chance of survival. So there was no difference in race, but that really had to do with the delivery of healthcare and not necessarily on a population basis. But if you looked at it from a population basis, about 55 out of every 100,000 Black persons died from COVID-19, whereas only 15 out of every 100,000 of non-Black died. And of course, as I said, they only made up about 20% of the St. Louis population. So significantly more risk of death because of more risk of contracting disease from COVID. So really briefly, these are the most up-to-date data that we have. We cut slices on these about every week. And I'm just going to show you some interesting things just about the current pandemic, at least for the St. Louis area. And I think this is probably, I'll just leave it at that. This is for the St. Louis area. So as you can see over time, the age differences have changed quite a bit. So this was our 75 and older population. And as you can see at the beginning of the year, end of last year, this was mainly who was being affected, was that population. Then the vaccination started, those really kicked in right about here. Oh, sorry. And there was a dramatic decline then in the admissions from that age group. And the same thing with the 65 and older, and that is the power of vaccinations. What made up a higher percentage then was this 45 to 65 age group, which is this green bar. Oh, I gotta quit doing that. And then what it was even more was this less than 45 years old population, which makes up the vast majority of our admissions now. So again, the power of vaccinations is shown in here. But it's a little bit different when you break it out by race. So this is the African American admissions. Huge percentage, over 50%, less than 45 years old. Smaller percentages up here, but there was already a smaller percentage over here compared to the non-Black population. And the reason for that is the distribution in age. So the length of life is shorter in the African American community. And so you don't have as high of a percentage here on any given day than you would than you would during COVID. And so you're always going to see a higher proportion in the non-Black community is this older population. And the younger population here has more significant healthcare issues than the 45 and younger population here. So you have to make sure when you're looking at these statistics that you understand the population that you're looking at, because it's different for different parts of the community.
Yeah.
And then the admissions data has stayed relatively flat for the last 3 months here. It pulses up and down. But if you remember back to that original slide that I showed you where it was 50%, it has come down. And so the Black population now is representing about 30%. And again, I think that is also due to targeted vaccinations and things like that to decrease that risk of becoming an inpatient in the hospital. I have a ton more slides here, but I'm going to be very brief in just updating on the vaccination status. So St. Louis has done fairly well. So this is our statistical area, which includes Illinois. And again, this was about a week and a half ago. So we were around 41% of first dose for the statistical area. If then you look at, we've been designated Missouri Highway Patrol Region C. We are, I believe we're leading the state. I'd have to check on that in percentage of vaccinated where we're sitting around. It's probably up to 60% now for first dose. But as of last week, it was 54.5, and St. Louis County, St. Charles County are sort of leading the way. And then you can also see how that, so the one thing to point out about equity is St. Louis City sort of drops off there after you get through some of these counties. Certainly some challenges to get vaccine into those communities. And then these are just different heat maps on how we take a look at vaccinations throughout our community. So I'm not going to spend a ton of time on that. I did want to highlight this one, which reflects what I just showed you about admissions. The 75 and older have a tremendous uptake of vaccine, 90% in some of our communities. But once you get to this 45, it really drops off, and especially when you get down to this 18 to 24-year-old age group. Unfortunately, this is the age group that we're admitting now, and that is because this age group is vaccinated. So again, the power of vaccinations. Let me skip down to
just quick question to interject that. So does that mean that the 18 to 24s are not being vaccinated, or it's just they've just become so recently eligible that we're still getting penetration there?
So it might be a combination of those. Okay. So I have 3 boys. So the limitation before was the 12 to 15 year age range. So anybody 16 and older could have gotten vaccinated before. So it was really at 12 to 15. I had a 15-year-old, and so he was waiting to get vaccinated, and he's fully vaccinated now. So that would be the age group that you'd be concerned about from from being allowed to be vaccinated, would it be that 12 to 15. But you know, as you could see here in this, that's why we made this cut at 18, so that we could see what this looked like, and it's still low uptake of vaccination in that age group. Okay. Now, certainly it's going to get better over time, but these are age groups where, again, it's low risk for sure, but it's not no risk, and it's also protection for the community.
Sure.
Really briefly, we started looking at poverty and percent of Black African American and vaccine uptake. So this is vaccine uptake over here. Just think about it broadly like that. This, and notice this pale right here. So darker is good, less dark is not as much uptake. And then this is percent below poverty, and this is percent African American. And you can see the correlation there. Low vaccine uptake, higher poverty, higher percentage of Black and African Americans. And this really just shows it in bar format rather than map format. As you increase your poverty rate, you decrease your vaccination rate. So a lot of work to be done there. And again, this is just a combination of those 3 different factors as well. So where you have high penetration of poverty and minority population or Black population, you have lower vaccine uptake. For various reasons. You know, we can't really pinpoint it on any one given reason. Some of it is hesitancy, some of it is, you know, unable to get off work, some of it is transportation, some of it is access. Well, there's a lot of different things.
That's one of the questions that I had for you. Like, so some of this is in our collective community's ability to respond, right? Is our impact ability to respond. But yet we talk about these items such as social determinants, like where you live, access to transportation, how close you are to a pharmacy, and then what you just mentioned, you know, getting time off work. What if you work, you know, irregular hours that, you know, doesn't. So how has this, what has the task force seen in terms of how has things like these impacted efforts to get vaccinations, and what can be done to address this from a community perspective?
Yeah, certainly a lot of factors to consider there. So I think the challenges with trying then to get as much vaccine or vaccinations completed has been having to change your strategy. So early on, of course, it was protecting those older populations, and then protecting more of the general population by having these huge mass events, right? So people would come to vaccine. But of course, those are people that also had the ability to, you know, take off work, drive down, wait in line for hours, blah, blah, blah. And so now that demand has waned, so you've sort of picked off all of the low-hanging fruit. Now you have to have a much more targeted campaign. And so that means instead of people coming to vaccine, now vaccine has to go to the community. So that's one thing. So one of it is a logistics and operations issue, and then the other part is the hesitancy issue. And so making sure you have the right message, but not even just the right message, but the right messenger. People in different communities listen to different people. And so you have to be able to combine that right message with the messenger. So whether that is having Black physicians talk to the community, engaging pastors and other religious leaders, other political types, or community leaders that have buy-in from the community. So as much as I would love to think that everybody listens or hangs on my every word, that's not necessarily true. And so we have to be very cognizant of that. And then there's a certain percentage that are homebound, frail, unable to get out. And so we have to create ways to get the vaccine to them as well. And those are all in the works, by the way. So I don't want to make it sound like we haven't been doing that. There certainly has been. There's always going to be a certain segment of the population that's just not going to accept vaccine too. And so we just have to understand and accept that, but get as many people as we can. So hopefully that answered your question.
Yeah, perfect. Thank you.
So again, these are just different ways of presenting data showing, where we have the most work to do, which is this upper corner up in here. And then some of the zip codes where we've seen low vaccination uptake, we're also seeing higher admissions. And so, like I mentioned earlier, on a statewide basis, you're seeing this in those communities where there's low vaccination uptake. Broadly, we're also seeing that at a micro level as well. So down at the zip code level also. And then this graph just shows that penetration. So zip codes with the poorest uptake of vaccine make up higher percentages of admission. And again, there's no magic to it. It's all science and math. If you have more people that are unprotected, the virus is going to find a way in there because all it wants to do is replicate, and it will find a way. So that's sort of where we are with vaccinations and with the equity lens on vaccinations and with the pandemic. So I thought I would just really briefly touch on COVID and cancer, and I will admit this is not my area of expertise, but I did do some reading before I put this presentation together, and I thought I would throw at least a couple of slides in here for discussion. And so one came from this journal article that I found in Oncology, the Association of Cancer Screening Deficit in the United States during COVID-19. And this was, I think, particularly true early on in the pandemic, especially when healthcare had to stop a lot of the work that we were doing because we were so focused on the pandemic. And I found this graphic particularly interesting. And so this shows the yellow dot is 2020, so the amount of screening that occurs for breast, for colorectal, and for prostate. And then the blue dot is 2019. And so blue dot would be your baseline. So you can see the baseline here, and then it's across different regions of the United States. And then, of course, the pandemic hit here, and you can see the screenings really decrease across the board in that March, April, May, and then starting to get back up in June. If you think back in June and July, that's where we had sort of a respite last year before it really ramped up. But you could see the impact of cancer screenings across the board. And then I read some about just getting cancer treatment was challenging as well. And then a lot of economic issues about job loss and being able to afford health insurance and things like that for treatment for cancer. And then I also found this other graphic from the American Cancer Society that showed sort of the trajectory of where, I think this is still an unknown, is the pandemic stressing the healthcare systems, reducing access to care, delayed routine care. And so you're going to end up with later stage diagnoses for cancer, which will probably result in some more poor outcomes. But again, I think we're still need to see how this is all going to play out over time.
Sure.
So anyway, that it really does conclude the things that I wanted to get across for you.
Nice.
I think I've gone through this in record time. So, but again, I didn't want to spend a ton of time on these slides. And I'm a huge Gary Larson fan. And so as I was putting together a talk about vaccines, I came across this one of his cartoons, and this may be the future of our vaccination strategy.
Could very well be targeting it. Take the vaccination to the community, right? And the target effort to get that out. Thank you for your words. I've got a question, and we had a question come up in the chat, and if you have just a few more minutes. But yeah. We are, here in the St. Louis area anyway, but hopefully we can extrapolate this out to the state, right? We are hospital heavy and acute care focused here in the St. Louis region. Yeah. And yet on the other, which is outstanding, it's really one of the strengths of the region, as we talked about back in March. But there's also a shortage of funding for public health and a shortage of information about public health. And so, as it relates to the pandemic, what impact did that have in the region and the state? And are there things that the task force would recommend to change that to have more impact in our region?
Sure. So I think just right off the bat for your second question first, I think without a doubt, we need to improve funding for public health across the board. Missouri is one of the lowest funders for public health of any state in the country. And sometimes people don't understand like how that really affects your day-to-day life, but it becomes acutely aware when you're having to deal with things like a pandemic. So let me share a couple of stories with you. Early on in the pandemic, as we were trying to figure out, how we were going to diagnose cases, how we were going to get testing up and running, things like that. The system that the state used to collect communicable diseases was, from what I heard, was this hand-built system that had been in place and held together with bubblegum and baling wire for like 30 years, and it was just incapable of handling this volume of data. And so so our public health partners were trying to interact with this system by sending faxes and phone calls and all of these different things. And so what I have said before, they were fighting a digital war with analog tools. There was just no way that they were going to be able to deliver appropriately for that. And there's many other things that you could say that were really, the curtain was pulled back and shown the poor infrastructure of public health in the state. And so without a doubt, now some of those things were then corrected, but the wrong time to try and correct things is when you're in the middle of a battle.
In the middle of it, right? Yep,
yeah,
sure.
So without a doubt, some lessons learned. Whether those are long-term lessons learned, I don't know. And then many of you probably heard, this quickly became a political football. Public health did, which is very unfortunate because these are very dedicated individuals, and some of them, had very serious personal sort of attacks on them, which was unfortunate because they really were out to try and do their best to help the community.
And I'm not speaking for you or even the American Cancer Society, but just me personally. It's ironic that would come up and that answer would say today on the day that bill is being signed. That it really takes away a lot of that
right.
stuff. So I don't mean to put you in a box on that, but I had to put my own little thing out there on that. Fran, one of our volunteers, I think, has a question in the chat. And so through your lens, what are some of the top items that ACS staff and volunteers can do to positively impact message or reassurance of vaccination safety, and which resources should we share?
Yeah, so let me share a couple of things. So a lot of people tend to think that there were shortcuts in developing this vaccine, which is absolutely not true. There's been decades of research on mRNA work. We were very fortunate that all of that past work had been done so we could pivot it to vaccine development rather quickly. And so there's that. The reason why vaccine was so readily available was because the government had actually put a big bet down that this was going to work and paid for manufacturing so that when the clinical trials were done, that we could roll it out very quickly. Typically, it takes clinical trials, then going through the FDA's normal approval process, and then you start production. We did all that in parallel and not sequential, which is why it seems like it was rushed, but it really was not. It met all of the safety profiles for any of the vaccines that have been developed by the FDA. And we've delivered more doses in the shortest amount of time with the highest safety profile of any vaccine in history, really in history. That shows you how good and how effective and how safe this vaccine really is. I mean, it is phenomenal from a medical and a scientific standpoint. This is unparalleled work that has occurred. And so those are some of the biggest sort of takeaways for me in trying to explain like how safe and how effective this vaccine is. Anytime you can get effectiveness up into the 90% range, I mean that's incredible. That's incredible.
Yeah.
You think on any given year, a flu vaccine is maybe 50% effective. So just compare it to that. It's really an amazing amount of work.
Just one quick question, if you can kind of peer into your crystal ball, as it were. What is the long-term impact of the pandemic on just healthcare delivery in general, but specifically in either exacerbating or overcoming the healthcare disparities that we're confronted with, that have been exposed during this time?
Yeah. So with the healthcare delivery, I think it really was a proof of concept that you don't necessarily have to be in the doctor's office to get medical care delivered. You can do it remotely. You can do televisits, and I think this is particularly true for the rural areas where there's not access to specialists and things like that. And so from that aspect, I do think it showed that the traditional way of delivering healthcare is not necessarily the only way. So there's that. From the health equity lens, so a couple of things. Don't forget, during the pandemic, there was also the George Floyd murder that occurred. And so I think that also amplified a lot of the health equity issues that we've been dealing with long-term in healthcare, in a shorter term with the pandemic, but this also put another layer on top of that. And so I can just tell you from our standpoint, from SSM and from some of our partners here in St. Louis, there's been at least 2 large healthcare systems that have created now chief community health officers for specifically this reason, is that we recognize we needed to be farther upstream. We needed to start dealing with equity issues as providers of healthcare, or else there's no way that we're going to build healthy communities on the back end. So I do think it's going to have an impact moving forward. I think people saw the power of everybody coming together to work on a common issue, being the pandemic. Whether it was elected officials, healthcare, business people, everybody that was involved in the task force saw that this is what happens when everybody's focused. So I'm hopeful that a lot of positive things about dealing with equity in the community are going to come out of this, but we just have to be very persistent about keeping it at the forefront and not letting these things of the past just go away once the immediate crisis is over.
He is Dr. Alex Garza, the Chief Community Health Officer with SSM Health and head of the St. Louis Metropolitan Pandemic Task Force. Dr. Garza, thank you so much for your time today. And of course, we cannot let you go without saying thank you for all of your work during the pandemic and keeping us informed and being that presence with us, even through the television screen and through the newspaper and what have you. During this time. Thank you for helping us survive this pandemic and hopefully come out stronger on the other side. And thank you for your time today.
Oh, appreciate it, Jim. Just know that there was a lot of people behind the scenes that nobody saw, and that were just phenomenal to work with and made my job easier. So thank you.
Thank you. And thanks to everybody that's been on this listening series today for joining us. The recording will be available and be sent out for those that you want to pass it on to your colleagues and other volunteers that they can join and learn from Dr. Garza's wisdom today. And thank you all for joining us, and we'll see you not in July. We'll take July off, but we'll be back in August to talk about advocacy and health equity. Until then, thank you all for being with us.